Hello, I am Mr. Bridge-Maddock, Consultant Bariatric Surgeon at Royal Derby Hospital. A lot of you would have already met or spoken to members of the bariatric team and are on the pathway to have weight loss surgery. This video is meant to provide you some important information about the different weight loss operations, recovery afterwards, and possible risks involved. Please listen carefully, take notes if needed, and you will have a chance to discuss in more details when you have your one-to-one consultation with the surgeon. There are three main operations I am going to discuss: sleeve gastrectomy, Roux-en-Y Gastric Bypass, and one anastomosis gastric bypass. All these operations have a lot in common, which I will explain first. Any weight loss operation is a tool for you to work with and change your diet and lifestyle to achieve successful weight loss. All three operations are very effective and offer significant weight loss that is often sustainable in the long term, but the overall weight loss each patient receives can vary a lot from patient to patient. As such, no operation can guarantee you to lose a certain amount of weight or cause more weight loss than the others. All operations are performed using laparoscopic or keyhole technique under general anesthesia. Before the operation, you will be asked to be on a special diet to reduce the size of your liver. This essentially is a very low-calorie diet regime to be followed for typically 2 weeks, just preceding the operation. Some patients may require longer duration of liver-reducing diet. It is very important for you to strictly follow this diet to allow the surgeon to safely perform your operation. Failure to comply with the diet may mean cancelling your operation on the day, or even worse, the surgeon may not be able to perform the operation because of the large liver. After the operation, you will follow something called as enhanced recovery, where the team will ask you to mobilize and perform breathing exercises on a frequent basis. You will start sipping water a few hours after the operation and remain on liquid diet for the first 2 weeks, followed by pureed diet for another 2 weeks. Most patients stay 1 to 2 nights in hospital, and general recovery takes around 2 weeks. During this time, you will remain on blood-thinning injections to reduce the risk of forming blood clots. It is common to have some abdominal pain and symptoms of sickness or acid reflux in the first 2 weeks after the operation, and you will be sent home with appropriate medications to help control these symptoms. As each day goes by, you will continue to feel better and these symptoms settle. In the long term, you should be able to eat most things, but in small portions. You will be advised to remain on lifelong supplements such as multivitamin and mineral tablet, iron, vitamin D with or without calcium, and 3 monthly vitamin B12 injection. You will receive regular follow-up by the specialist bariatric team for a period of 2 years and then discharged to your GP. Following this, you should receive annual follow-up by your GP and blood tests to monitor for any nutritional deficiencies. With any operation, there are some risks, although majority are rare. The short-term risks common to all operations are risk of dying. From these operations is very rare and not directly during the operation, but due to some severe complications that you may develop after the operation. Staple line or anastomotic leak or bleeding, around 1 in 100 chance. This may require blood transfusion, reoperation, endoscopic treatment, or prolonged treatment with antibiotics. You may require a prolonged hospital stay. Damage to internal organs such as the liver, spleen, or bowel, which may need further operation, or perforation of gullet or stomach that may require further surgery. Blood clots in your legs or lungs that may require treatment with blood-thinning medications. Infection of the wounds may need antibiotic treatment or result in delayed wound healing, or intra-abdominal infection or collection that may require treatment with antibiotics or further procedures. Some risks from general anesthesia, such as chest infection or heart attack, or occasionally nerve damage in the arms and legs that may lead to temporary or permanent numbness or weakness in your arms or legs. Long-term complications that are common to all operations can be nutritional deficiencies, especially if you do not take your supplements regularly after the surgery, some of which may make you ill or have long-lasting effects on your health. Development of dumping syndrome or reactive hypoglycemia, causing symptoms such as lightheadedness, palpitations, and faintness, followed by abdominal cramps or diarrhea, with resultant effects on your ability to do normal activities such as driving or working. These are more likely after gastric bypass. Development of temporary or permanent lactose intolerance or other food intolerances. Development of gallstones. This can cause symptoms and may require further surgery in future. Significant weight regain in the future, especially in patients who do not continue the necessary dietary and lifestyle modifications after surgery. Scars with possible development of raised hypertrophic or keloid scars. Port site hernias that may need further surgery. Intra-abdominal adhesions which may cause bowel obstructions needing an emergency operation. There is risk of developing loose or excess skin with risk of recurrent infections which some patients can find unsightly or troublesome. If you need surgery to deal with a complication related to any weight loss operation, this may be associated with prolonged recovery, hospital stay, as well as effects on your quality of life, financial earning capacity, and relationships. I will now go on to talk about the specific operations and show you some schematic videos. Laparoscopic sleeve gastrectomy, and this is the schematic video of sleeve gastrectomy. We make about 5 small keyhole-sized cuts to access your stomach. We divide and seal your stomach using surgical staplers. At operation, we will remove almost 3/4 of your stomach, allowing you to eat only small portions, leading to fullness. Sleeve gastrectomy is a completely irreversible operation. On average, you can expect to lose up to 25 to 30% of your total body weight over a period of 12 to 24 months. Short-term risks specifically to sleeve gastrectomy are risk of dying, 1 in 1,000. Sleeve is overall slightly safer operation than Roux-en-Y Gastric Bypass, and we may offer you this operation especially if you have other major problems with your other organs such as heart, lung, liver, or kidneys. Long-term risks are heartburn or acid reflux symptoms, more common after sleeve gastrectomy. If you have significant symptoms of acid reflux, sleeve gastrectomy may not be suitable for you. Some patients may experience regular symptoms that affect their quality of life, need lifelong medication for symptom control, and rarely may require conversion to Roux-en-Y Gastric Bypass. Barrett's esophagus is very rare. These are changes in lining of your gullet due to long-term acid reflux, which can rarely develop into gullet cancer. Where you do develop Barrett's esophagus, this may require regular surveillance by endoscopy, which is a camera into the stomach, and certain treatments to be performed, such as ablation to the lining of the gullet. Twist or narrowing in the sleeve that can cause difficulty in eating and having food sticking. This may require treatment by endoscopy or a reoperation such as conversion to gastric bypass. Now I'll talk about laparoscopic Roux-en-Y gastric bypass. This is a schematic video of Roux-en-Y gastric bypass. Again, similar keyhole cuts are made as in sleeve gastrectomy. Roux-en-Y gastric bypass involves making a small pouch of your stomach and joining it to your small bowel. And then a further joint is made between your small bowel. No part of your stomach or your bowel is removed at the operation. The operation is permanent, but if you develop some rare severe complications, then the bypass can be reversed. It allows you to eat small portions, leading to fullness, as well as reduces absorption of the food you eat, resulting in weight loss. On average, you can expect to lose up to 30 to 35% of your total body weight over a period of 12 to 24 months. Bypass may be more appropriate for some patients, such as those with diabetes or patients who suffer from symptoms of acid reflux. Bypass may not be suitable if you have had other major operations on your abdomen or suffer from other conditions such as Crohn's disease or colitis. Bypass has been there the longest, and we understand more about the Roux-en-Y gastric bypass than the other two operations. The short-term risks specifically for Roux-en-Y gastric bypass are death in 1 in 500 patients. Bypass can be riskier for patients who have major problems with other organs such as heart, lung, liver or kidneys, or for some very large patients. Bowel obstruction risk around 1 in 100, and this may require emergency operation. In the long term, there is a risk of anastomotic ulcer or narrowing. This is most commonly seen in patients who smoke and take certain painkiller medications such as ibuprofen or steroids. This can cause significant pain and difficulty in eating and may require further medical treatment and occasionally further surgical or endoscopic procedures. As such, after your gastric bypass, you should not smoke or take ibuprofen or similar pain relief medications. Internal hernia. This is reopening of the spaces around the joints that can cause pain or rarely bowel obstruction. This happens as you lose weight after gastric bypass and is a lifelong risk, although rare. This will require further surgery to close the hernia spaces, which can usually be done in a keyhole fashion. However, internal hernia can sometimes present as an emergency with bowel obstruction or dead bowel that requires emergency operation. Now I'll talk about laparoscopic 1 anastomosis gastric bypass. This is a schematic video of 1 anastomosis gastric bypass, which again is done by doing similar keyhole size cuts on your skin. 1 anastomosis gastric bypass involves making a long narrow pouch of your stomach and joining it to a loop of your small bowel. As the name suggests, unlike the Roux-en-Y gastric bypass, there is no second joint involving your small bowel. No part of your stomach or bowel is removed at the operation. The operation is permanent, but if you do develop some rare severe complications, then the bypass can be reversed. It allows you to eat small portions, leading to fullness, as well as reduces absorption of the food you eat, resulting in weight loss. On average, you can lose around 30 to 35% of your total body weight over a period of 12 to 24 months. 1 anastomosis gastric bypass may not be suitable for patients who have regular symptoms of acid reflux or are known to have certain conditions such as Crohn's disease or colitis, or have had major previous operations on their tummy. Some very large patients, although, may particularly benefit from one anastomosis gastric bypass, as this operation can lead to more weight loss. Risks are pretty much similar to Roux-en-Y gastric bypass. Short-term risks are death, about 1 in 500, bowel obstruction, although this is very rare compared to Roux-en-Y gastric bypass, as there is no second joint further down in your small bowel. In the long term, there is risk of anastomotic ulcer or narrowing, which is similar to Roux-en-Y gastric bypass. And again, smoking is prohibited after any type of gastric bypass. Internal hernia, very rare after one anastomosis gastric bypass, as there is only one joint, but still a rare possibility. Acid or bile reflux, which may be severe and affect your quality of life, need medication for symptom control, and rarely, if severe, may require conversion to Roux-en-Y gastric bypass. Barrett's esophagus, similar risk as sleeve gastrectomy. However, overall, this is very rare. This brings me to the end of the video. Hope this was useful. Please feel free to share the video with your friends and family and discuss with them. During your one-to-one consultation, the surgeon will cover any doubts and questions you may have. Thank you.